Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Hey everyone, welcome back to another episode of Boombostic Health. This is episode 28. I'm extremely psyched to have my friend and colleague Dustin Suntheimer on today. Dustin is somebody who has an incredible range of expertise on the oncology testing side and has been around healthcare for quite a while. We're going to get into a lot of details about how the state of the art of oncology testing is playing out and what kinds of guidelines are being applied now in the best possible cancer diagnostic situations. And I think about back when my mom got diagnosed with colon cancer back in 2000. There was really a limited set of diagnostics back then, and they didn't do any kind of genotyping or any of that. And so fast forward to today, and now we have this whole range of what people refer to as omics. And so I'm going to want Dustin to also help the audience here understand what that means, and then understand that when somebody's faced with a cancer diagnosis, why it is that today things are better than ever in terms of solving that, and also why the future is really bright for these diagnostics and how they can bring better therapies to patients to make it so that people can get better faster and more frequently, and also ideally, be more preventative. So I'll turn it over to you, Dustin, though, to introduce yourself. Maybe you can even tell us a little bit about GoPath, where you are today, and how you got there and why you got into healthcare.
Yeah, no problem. Thanks for having me, Brad. So my name is Dustin. I am the director of commercial operations at GoPath Diagnostics here just outside of Chicago. We are a fully digital laboratory that is backed up by a molecular and AP backbone. And what we do is, like you said, we diagnose cancer and help our physician, our client, help their patients get better faster through the use of traditional AP diagnostics, followed up with a cadre of molecular testing, whether it be somatic testing with tumor profiling or germline testing that goes beyond just the patient into familial inheritance and how you can use the laboratory to extend diagnostics beyond the patient into the family and the larger community.
Awesome. So I think we need a little bit of a glossary of terms.
Yeah.
There's so many different terms that get thrown around. So could
Sure.
you first start with, like, what does that mean, an anatomic pathology or AP laboratory? What does that
Okay.
mean to be fully digital? We have a lot of really smart healthcare leaders that follow this, that are innovators, but some of them may not be immersed in the lab industry like you are.
No, that's fair. That's very fair. So anatomical pathology is the examination of actual tissue, and in this case, tumor tissue. And so we will bring that into the laboratory. We will prepare it. We will make slides. We will section the biopsy. They take a biopsy. We look at the tumor. We section it. We put it on glass slides, stain it with different antibodies, with stains that highlight the disease. That is then examined by a pathologist who can render an initial diagnosis. Now, when I start talking about the digital aspect of it, is that for the past, since pathology started looking through a microscope, they were looking at a glass slide. Today, because a lot of different factors in the industry, we are now in a digital age where these images are scanned into a whole slide image that is uploaded to a server, into an image management system, where a pathologist can look at this slide, and regardless of where he's sitting, or where he or she is sitting. So if we prepare a slide here in Buffalo Grove, we can have a pathologist look at it digitally across the office or across the country. And now when I start talking about when we are an AP lab, the anatomic piece, that's the tissue piece. Now the molecular piece is when we actually find the tumor, when we take the tumor and we do something called a molecular profile on that tumor. We're looking at the various genetic mutations within that tumor that help drive therapy and additional diagnostic work. Now there's two types, right? Well, there's multiple types, but for our laboratory, we concentrate on two very specific types of molecular testing. Somatic testing, which is specific to that tumor, to that patient's tumor. And then we do something called germline testing, which is the whole genome of that person and how those particular mutations can affect an outcome or even a family members up and down the family tree. Does that help?
Okay. I think so. Yeah, I think so. So the net of it is we're able to go to the genetic level and see exactly how an individual's genes are going to respond, how an individual will respond to a given treatment potentially, or their specific cancer, what the genetic profile is of that cancer, so that you can treat it more effectively. Is that fair?
Absolutely. Absolutely. And then there's the opposite side of that coin that says this particular treatment for a specific mutation and a specific cancer type. There are guidelines that say mutation X equals medication Z, right? But what that does is that helps eliminate all of the other unnecessary treatments that a patient could undergo, right? So it's twofold, I guess would be a better way to say that, is that it directs your treatment, but it also directs you away from the treatment that is ineffective and or harmful to that patient,
Gosh, that is so
which is
exciting. I think back
it
to my
is.
mom's
It
experience, and
is.
she actually had more of the trial and error kind of treatment. And the oncologists were doing the best that they could do at that point. And if I think about today, the fact that you could know in advance a certain treatment was not going to work. And because, this treatment, it is for cancers, especially when you get into chemotherapies and these types of, infused therapies that end up circulating throughout your entire body, they hurt you in certain ways there's no way around
Absolutely.
it. And in my mother's
Absolutely.
case, she ended up passing away after an experimental treatment that she had a severe negative reaction to. And I'll never forget the oncologist saying, "We've never seen anybody respond this severely to the treatment." And it was code for she just got overdosed on a treatment that wasn't helping. And she died sooner than she would have otherwise. Now, she had stage 4. It was way too advanced to ever actually cure her. But she died on December 23rd. And candidly, if they hadn't had to do this trial and error thing where she was more like a guinea pig, candidly, she would have at least survived to see Christmas, one more time. So it's a
You know,
pretty palpable issue.
it is, and it's when and so Bradley, when you start talking about, your one of your initial questions is why I'm in healthcare, and that's one of the reasons, right? She didn't get to see that Christmas, and I'm sorry, for that for you and for you and your family. But looking at where we are today, had the availability of some of these advanced molecular assays been available and used by your mother's physician, outcome possibly could have been different. Now, one of the things that you did say, though, that is also a key factor and a key advantage to these molecular diagnostic tests are that she was found your oncologist was at least knowledgeable enough to know to get her into a clinical trial. I'm sorry it didn't work out, but that is an advantage of these molecular tests, because if a traditional therapy is not working and you are advancing through the stages of cancer, and your oncologist and your pathologist are working together, with your genetic markers, with your diagnoses, with those test results, those make you eligible for clinical trials that either, that can help you. They can then let family members see an additional Christmas. And that's
Right.
that's some pretty amazing stuff.
It's huge. And I assume that the inclusion and exclusion criteria for a lot of these trials now include biomarkers and specific details that would relate to a more advanced type of testing panel. Is that fair?
100%. In most cases, it is almost entirely up to your genetic results.
Wow, that's exciting to know that this it's just so much more capable. So let's zoom out for a second. I hear people throw around this term omics all the time, and I think almost nobody knows what that is. It's like but they don't want to say they don't know what that is because then they feel like they'll look stupid. It's the same thing with like with AI, right? And so you ask somebody, what is AI? What does it do? Or everybody now that uses Chat GPT. I was in a room giving a keynote speech a few weeks ago out in Orange County, and it was a lot, it was about AI. It was about the promise of AI and advancing healthcare. And I said, raise your hand if you use Chat GPT. And everybody raised their hand. And I said, raise your hand if you know what GPT stands for. And nobody raised their hand. Zero people in the room knew what GPT stands for, which is generative pre-trained transformer, which those words matter as you think about more of the future of AI, but we won't get into that right now. But I think it's the same with omics, where people talk about it like they know, but they don't. Could you just help share, like, what does that mean when we say you're using the omics, to do a better job with diagnosing people?
Yeah, okay, so sure. I'm gonna so there metabolomics, proteomics, genomics, when you start looking at the different cellular areas, right? And so the proteomics is, how protein synthesis affects your protein synthesis, excuse me. Genomics, which I'm more familiar with, is how your genetic expression is going to help metabolize their particular compound, and being able to use that information, wherever the information is coming from, right? Being able to use that information in a more holistic fashion. Now, what does omics mean? Yeah, I don't know. I don't know what I can't
Well,
tell you
so
what
here's
GTP
the
stands
actual, using Gemini. Here is the actual
for.
definition of omics. Okay. Omics refers to a group of fields in biology that involve studying the totality of specific molecules or processes within a living system using high throughput technologies. It essentially means looking at the complete set of something, like all genes, genomics, all RNA molecules, transcriptomics, or all proteins, proteomics, or all metabolites, metabolomics. So it's this idea of being comprehensive and looking at the systems that relate to how biology functions and using high throughput technologies to do that. So you're in the business of omics because you focus on genomics. Is that right?
That's correct. That's
Okay.
correct. So again, looking at it from beginning to end, right? Beginning to end. And is another way in my mind to think about that, is looking at the entire system. Okay. So great, a great way to how does that relate to what we do in diagnostics? So a lot of these things are pathways, but they're pathway driven. And so if a particular tumor is showing a set of mutations, these mutations in most cases will follow a set. You'll have a mutation here, and it's going to go. And without getting into all the initials and the mutational names, I'll just use very generic A, B, C, D, things like that. So if you have mutation A, it's going to go one of a couple different ways. It's yes, no, or ambiguous, right? And so if it goes one way, and then that again is another mutation. From that mutation, again, it's going to have one or two or three different mutations from there. And then it is a cascade. And so being able to look at the the genomics of cancer diagnostics, that's how we work with it. And then being able to take, again, one step back out from the somatic world, again, looking at the mutations within a specific patient tumor type, and then zooming out to the germline testing, the hereditary testing that looks at your entire genome for what you were born with, what the mutations are that you're born with. Now, being able to tie all that together, tie all of that information together, which omic that is called, I'm not 100% sure, Brad. It's definitely it's approaching it's the standard of care that we deliver here, being
Right.
able to
And so,
wrap all
and
that
so,
information together.
so within this cutting edge technologies bucket, I've heard a few different things. Genetics now, onco target, onco tracking are three
Yeah,
areas.
yeah.
Can you talk to me about what
Those,
those
yeah, absolutely. Again, looking at our genetic panels, right? So these are some of our flagship product is something called Prostate Now. It is a germline test for men undergoing prostate cancer treatment, and it is a germline test with clinical indications for treatment. OncoTarget. is a 500 gene assay that GoPath has been offering now for many years. It is a pan-cancer test that looks at over 500 genetic mutations across all tumor types. And then what was the other one you said? You said genetics
Onco
now?
tracking.
Onco tracking. Very important. So in a cancer patient's healthcare journey, they are going to go from diagnostics to treatment and therapy and then aftercare. And then, so what onco tracking does, it is an assay specifically designed to track MRD, minimal residual disease. And so what that is going to do is every 3 months after a patient has been cleared of cancer, we are going to get a specimen, a blood specimen, and we are going to look for, and it's individualized. Another term that we can add to this conversation, Bradley, is precision medicine. And this is almost by definition precision medicine per patient, because we will take a cancer type, we will take the driver mutations that are most prevalent within that patient, and then we will design an assay specific to them that says, all right, every 3 months, we are going to look for these 5 to 8 to 16 mutations within their circulating blood. And if we find them, then we know that the cancer is coming back. Obviously, we don't want to find them. We do not want to find these at all. And that's the idea. So every 3 months for at least a year, preferably 2 years, what we're going to do is we're going to be getting a specimen. We'll look for those mutations, designed specifically for that patient, and then report back to the physician clear.
So this is a type of surveillance testing where it's tracking to see if you've got a cancer that has been treated and now you show in the first test that, oh, good news, no sign of disease. But cancer is this insidious thing that once you've had most types for some period of time, you're at high risk of it recurring. So this
Sure.
tracking that you're talking about uses advanced testing that's a blood test to
That's
identify
right.
the signs. Is it it's proteins in the bloodstream, or what is it finding in the
Circulating
blood?
DNA. So
Circulating
circulating
DNA.
DNA and RNA. Yeah. Yeah.
Okay.
And so the tumor will give off a specific genetic signature
Okay.
for the mutation, right? And so we are able, through a specific type of PCR testing, which is a genetic testing, we are able to identify the genetic signature of those mutations and indicate a recurrence or remission.
Okay.
That's what everybody hopes for. Is we don't want to find those signals at all.
Right. And are there specific, you mentioned prostate, for example, as a cancer type. And part of, as I understand it, the key to prostate health management is this PSA testing. And PSA testing has been sort of a standard to try to show, do you have elevated levels that might correlate with having a higher risk of having prostate cancer? Like, is there something that you're doing that relates to finding this early, or even doing things that can help you preempt a worse downstream issue?
So earlier detection, it's not, when you start talking about, when you start talking about preventative and not necessarily surveillance, but what you're talking about is screening and being able to go to pushing the diagnostics forward in the disease state. PSA has been used, digital DREs, digital rectal exams, family history. This is family history and genomics is where you can where things start to get interesting, right? I'm sure that you and almost 100% of your listeners are familiar with the breast cancer gene BRCA, BRCA, BRCA1, BRCA2. And when that discovery was made, in my opinion, revolutionized. It was one of the revolutionary discoveries in breast cancer care. And then that was one of the first heritable genes that were identified and then commercially made available. My personal anecdote, my aunt, one year, she, in a family email said, "Hey, everybody, I want to let you know I've just been diagnosed with breast cancer and I'm going to proceed with therapy and mastectomy." And everybody was shocked. And That was at the time when BRCA was readily available. So me being in the business that I am, got right back on the email privately, not to the group, but it's not a reply all kind of a thing, and said, you know, my aunt, please make sure that you have your BRCA testing done. Please make sure that your daughter gets it done. And then I'm going to talk to it was my mom's sister. So I talked to my mom and my other aunts individually and said, hey, your sister has breast cancer. Maybe everybody should get some BRCA testing done for preventative, right? Now, how does that relate to prostate? Exactly the same. So if you have a family history and you have a little bit of and I want to preempt this with, I'm not a physician. I am not a pathologist. I am just somebody that cares about, I'm deeply invested in patient care and diagnostics. So this is not medical advice. This is just me talking. You know, if you do have a family history and you have, you know, if anything is of suspicion, get your genetics done because then you know what you're predisposed to. You know that you know that there are lifestyle changes that you can make, that you know that there are treatment options available to you if anything were to happen. And I think that right there is just the power of genetics, the power of the testing that we have available to us now. But you have to make sure that you're receiving the testing. You know, there is a bit of consumer awareness, you know, because we are all healthcare consumers. And so you have to be aware of these things, but at the same time, so does your physician. You know, and if
And
your
so
physician,
as I mentioned earlier, Dustin, my mom died of colon cancer. I get colonoscopies periodically. Is there
yeah.
some other thing that I should be testing to determine if I have a higher risk or, you
So
know?
great question. Great question. Have you already had genetic testing done? Have you had Lynch testing done? Have you had, so
No.
do you know? Okay. That's one thing that you could possibly do. And then it's going to be, you know, you're already with family history, you're already at risk. And your physician knows this, your personal physician knows this. That's why you will have a more advanced uh colonoscopy schedule than somebody without a family history. You'll get them more frequently, right, for surveillance and screening. Whereas somebody that does not have the family history or any indications that their treatment plan will look like. Now, what can you do diagnostically? Yeah, you can look for you know, genes associated with different types of colon cancer, right?
So Lynch
Or
testing,
disease, Lynch,
right?
right?
So Lynch testing is specific to Lynch syndrome. That
That's right.
is indicated. It's a hereditary
That's right.
type of inherited condition that increases the risk of certain cancers, like colon cancer.
That's right.
And that's a genetic test I could have done. I do have colonoscopies. I have fortunately been healthy. It's interesting, you know, from a medical history perspective, there's no real knowledge of any other colon cancer within anybody that's been in my family. But it's also interesting that back in my grandmother's days, who she passed away probably, well, gosh, 10 years ago now, but she was in her 90s, I think 99. Nobody knew what people died of. It was like, oh, you know, that gal, she died of stomach pain.
Yeah,
Like,
consumption.
yeah, like, what is that? So I guess, how do you make the determination on, is it beneficial to have an additional genomic test? And I assume insurance wouldn't pay for me to have a Lynch test, most likely, would they?
We could have that. We could have the coverage. We could have the coverage conversation offline. You know, that is a that's always a concern.
And look,
But
for me personally, I'm happy to pay the money if it
sure,
is something that will help me be healthier. So I was just kind of curious as it relates to our listeners. People typically think about what's medically necessary. And I know if you have cancer, doing a genomic analysis, that tends to be paid for because it helps to treat it and save the patient a lot of pain and the insurance plan a lot of cost. But anyway, it's just interesting. What's really interesting is that there don't seem to be well-known, understood guidelines for this kind of thing. I'm in the healthcare data space. I have been my entire career. I'm highly educated. I talk to experts all the time. And I had a primary care concierge physician for years, and never did he say, hey, you should have a Lynch test potentially. It's just interesting how there isn't a general set of guidelines, is there? Or like, how is this getting fixed? Because if people don't know about
So,
it, doesn't matter if the test exists.
well, okay, a couple things there, a couple of things there, right? Are there guidelines once you realize that there's something wrong? Well, then yes, there are. The NCCN guidelines are pretty unambiguous on very specific steps and protocols is what to do, right? But pushing that forward to primary care. Now, again, not a doctor, but if I'm thinking, okay, my family physician or your internal medicine physician or whoever it may be knows you have a family history, then it's not uncommon for a good example is okay, you're getting your preventative colonoscopies, but why not take that one extra step and say, why don't we look at some hereditary testing? Why are we looking at? Now, are there guidelines there? I can't answer that question. I don't know. I'm going to look today though, because I do think that that's a very valuable piece of diagnostic information because testing like that is done one time in your life. You only ever have to do it one time. What your genome doesn't change. The only time it changes is then we call that cancer, no, that and a specific tumor. But you only have to do that genetic testing one time, because your inherited genetic code isn't going, it doesn't change. It doesn't change over time. And so if you have a mutation that says you are more predisposed to a particular type of cancer, that's going to remain with you your entire life.
Sure.
So
Yeah.
what can you do then?
Yeah. Right. Well, and very proactive screening, right? Lifestyle is
Absolutely.
important, but I think
Absolutely.
about even after my mom had died of colon cancer, I think the guideline at the time was wait until you're 50 to get your first colonoscopy. I was like, forget that. I started when I was
No
like
way.
30 something.
Yeah.
And, I feel happy that I have done that. In fact, one of the colonoscopies had a polyp that they removed, and it's no big deal. It's like there's nothing cancerous or precancerous or anything, but it's just one of those things that you just never know down the road 20 years. Maybe that could have turned into something bad. So that screening makes a lot of sense to me. Well, I'll look into the Lynch testing. I was familiar with it, hadn't really thought about it in a while. And, I also think about my mom in 2000. They never tested her for that. There was no genomic
Yeah.
done. And so maybe she had it. There's no way to know it at this point.
Yeah. Yeah. Yeah.
So,
Well,
yeah. Okay, go ahead.
yeah. Well, I was going to say if there's a mutation and if you have the mutation, then either came from mom or dad.
Exactly. Yep. Yeah, for
So,
sure. Yeah. You'd hope.
yeah. Yeah.
So
Different
in any
conversation,
event,
but yeah, yeah.
yeah. Okay. So let's change subjects completely. Take a quick
Sure.
detour. So you were out in Indianapolis at our Healthcare Innovation Summit,
Yes, I was. Yes.
and
Yes.
had you
What
been to the Indianapolis Motor Speedway prior to that?
So I had, as a kid, I mean, a young, like I was trying to remember. I actually called my aunt, the same one with the breast cancer, took me there one time, and I said, when was this? So I think I was about 11 or 12 when I went. So that was a while ago. That was a long time ago.
Okay. All right. So you barely remember it.
No,
Yeah.
no, no, no.
Well,
It
it's a
was
pretty amazing. They call it the greatest spectacle in racing, and we
well
did.
deserved.
Yeah, for a good reason. I think when people just roll into the actual track, which is where we hosted the Innovation Summit day one, just the magnitude of it is you just can't even describe it.
I'll tell you, I have still. So it hit. So what has it been now? 2 or 3 weeks since the summit?
Yeah,
3
3 weeks.
weeks? Yeah, I'm still the people that I haven't talked to in the office. I am still raving about this summit. The location, the group, the location was nothing less than stunning. We're trackside. We're watching these beautiful machines just go by what was the track speed that day? 35 miles an hour. It
I think
was
that was the high. Yeah.
incredible to see that. It was incredible to see that. And then watching the pit crews work, seeing the engines, seeing the machines up close and personal, it was phenomenal. But that, being that close to the action, being, touchable close was outstanding. But the group of people that you had gotten together to discuss various topics in healthcare, whether it be data, whether it be the genetic aspect, testing utilization, the IT innovation, that was astounding. We are still connecting on LinkedIn. We're still sharing emails. We're still setting up meetings to for follow-up. It was an incredible event. And, for a thank you to you for inviting me. And I don't know if this would be the great spot, but Laurie Smith, if you catch a hold of this, good job on all your planning and effort there and your entire team at HC1. It was phenomenal. It was a
Yeah, it
phenomenal
was a
event.
team effort, and I think you're right. The people that were there made it awesome, and I think
Incredible.
continue to build on it after having such a successful year one. I'm already getting people asking if they can be invited next year, which is so
Yeah,
the
no doubt.
when you think about the metaphor of racing and what we witnessed there and healthcare, there's
Perfect
this
parallel.
it is. Yeah, it's like the performance is always being measured. The everybody's working to improve to make it so there's a higher level of performance, but safety is a huge consideration, and
Right.
I think that's also a healthcare parallel. We talked about some of the stat or some of the interesting trivia on the race, which the first
Let me
ever
know.
race, 1911, we got some funny answers too. Like I remember one. It's the greatest blank in racing, and the one of them was the greatest event in racing. And he said it's the greatest spectacle in racing, which is a funny thing. But the year one of the race, 1911, the winning car, the winning driver went on average 74 miles per hour. And fast
I
forward to
know.
now, yeah, now it's 230 in that range. And it's just incredible the increase in performance while a corresponding significant decrease in risk in terms of the potential to be injured or worse, killed. And so I think that's a parallel to healthcare too, is how do we get to where we go from the 74 miles per hour we're going now to the 230 so people can live better your lives and longer and do that in a way that's aided by these advanced diagnostics. And I also think about that from like an engine perspective. They're monitoring everything all the time. And obviously, the human system is much more involved and advanced. But I think that's the promise of omics, similar to like with the engine, you break it down to the components, you monitor in a certain way, you tune in a certain way. With omics, as that becomes better understood, and you utilize artificial intelligence to identify these signals that a human might never notice and pick up on. Now you can start preventing and helping to make it so that nobody has to die from these certain diseases. And heck, I think about testicular cancer used to be a death sentence. And then Dr. Larry Einhorn, who actually is incidentally out of Indianapolis, developed a treatment protocol that ended up making it so it was a totally manageable type of cancer. And I wonder how much more of that, like, are we seeing, Dustin, because of these advanced genomics and this ability to get into this broader omics world and get the right people in the right trials? What is that doing to advance the actual treatments that are getting to the point where cancers that used to be not something you could really manage to something that you are managing? Are you seeing some promise there?
Yeah, yeah, yeah. It's in going, Bradley, looking at the comparison, 74 miles an hour, 230 plus miles an hour, right? And I'm not going to say we're there, but we're on track, to use the pun. We have gone from, cancer being you're sorry, get your affairs in order. You don't have much longer, right? To, the next iteration. What was the trivia question? What was the piece of safety equipment that
Oh yeah.
allowed the
Well, what
second
was it?
driver, right?
What was it
The
that
rear
made it
view
so you
mirror.
didn't need a second driver? Yeah, or a second person in the car?
Yeah, the rear view mirror, right? Something as simple as that. And then looking in the rear view mirror as we're moving forward into these diagnostics, right? Is that we are now in a place where it went from recognition of disease to diagnosis of disease. Now I don't know if we're at 230 plus miles an hour yet with diagnostics, but we're getting there quickly. Our medical knowledge with the assistance of AI in all of its forms is rapidly increasing our knowledge of cancer and the mechanics of cancer. Again, using looking at it holistically, right? Through the lens of the various omics that are available to us. When is it going to go away? I don't know. Cancer's like it's insidious, just like you said. It It changes, it mutates, but if we can understand the mechanisms, and that's what we're trying to do, is understand the mechanisms of how it changes, we're going to get there a lot faster. And by partnering with companies like, like HC1, being able to understand that data, being able to understand the longitudinal data of these treatments is going to be paramount to the advancement of medical, especially oncology.
Right. I would agree. So, last question as we're about to wrap here.
Sure.
It seems like genomic testing could potentially be applied not in the most distributed way across all different demographics. Like some people might just think, yeah, in order to have that benefit, you need to be wealthy. Is that the case, or is this something that's becoming a standard of care and it's accessible to the broader base of deserving patients?
It should be. In practice, is it? Unfortunately not. With staying, let's steer clear of the socioeconomic factors. Let's just talk about the practice of healthcare. Now, according to the American Cancer Society, only about half of the people who are eligible for this advanced genetic testing are even receiving it. Now, if you think about that, cancer hits across every socioeconomic demographic everywhere, right? Cancer does not care. It does not discriminate. So if you think about that across our society, that means from the lower end to the higher end, people are getting cancer. Now, where it comes into play is your knowledge, but along with your physician's knowledge, is your oncologist, your pathology, being able to understand what the National Comprehensive Cancer Network's guidelines are that say, okay, if you have tissue diagnosis, you are then eligible for molecular profiling. If molecular profiling says this, it is going to dictate treatment. If it dictates treatment, what does your germline mutational landscape look like? And then being able to apply that to your therapy and your care, and also extending that beyond to your family, right? Now, when you start asking questions, is everybody receiving it? Unfortunately, no. There have been proposed guidelines are there. Everybody knows that there are guidelines. So whether they follow them or not, that's the question. It's okay. So why aren't they being followed? Are they unaware? Are they unwilling, unable? Are they stuck in their ways? Those are questions I can't answer, but I do think it creates one heck of an opportunity for physicians to partner with their laboratories, their pathology, and using the data that is available and then creating a better patient experience. That's what I truly believe. And I think that's where the opportunity, the trifecta, right? The treating physician, your data, laboratory, so Dr. Smith, HC1, Path Diagnostics, whatever that triangle may look like.
Right. It makes a ton of sense, Dustin. Well, thank you so much for sharing all of this with the audience at Boombostic Health, being part of the Boombostic Health community, and for the good work you're doing to help advance cancer diagnostics. It's just really so critical to the future of healthcare in our entire country and in the world. And so thanks for all the good work you're doing there.
Bradley, absolute pleasure to be here. Again, thanks for the Innovation Healthcare Summit a couple of weeks ago at Indy. Phenomenal. I think also events like that. I think events like that are going to drive healthcare forward too. Bringing minds like that together in one room, the potential is amazing. Thanks again. I look forward to seeing you again soon.
Absolutely. All right. Well, thank you everybody for joining us here on the 28th episode of Boombostic Health. We'll look forward to seeing you next week. Take care.